CT and MRI excel at capturing structural anatomy frozen in time. Nuclear radiology maps physiological action, tracking how an organ functions minute by minute. To evaluate the gastrointestinal system, we use specialized radiotracers engineered to mimic natural biological components. Depending on the test, these radioactive compounds behave like solid food, liquid bile, or red blood cells. Because the human body is constantly processing these components, a GI scintigraphy scan captures a moving target. Interpretation relies on a mastery of tracer kinetics. The clinician must know exactly where a radiopharmaceutical should be at any given second, and precisely why it might fail to reach that destination. Clinicians have to identify when biological artifacts are skewing the data, and they routinely deploy pharmacological agents to intentionally manipulate a patient's internal physiology. GI nuclear imaging is an active diagnostic process. You mathematically and chemically force the body to reveal its functional failures. The gold standard for evaluating delayed gastric emptying, known as gastroparesis, typically seen in diabetic patients, is the technetium-99m labeled sulfur colloid scan. Look at this time activity graph. During the test, a patient consumes a standardized radioactive meal of liquids, solids, or both. We map the rate at which those contents leave the stomach. The trajectory of the liquid meal shows a rapid, steady decline, as fluids empty almost immediately. Solid food follows a distinct timeline. Notice the flat section at the start of this second curve. This period of zero emptying is known as the lag time. Physiologically, this lag time represents the minutes required for the stomach to mechanically grind solid food into particles small enough to pass into the intestines. Liquids require no grinding, so they lack a lag time. In a clinical setting, an elongated lag time is the specific diagnostic marker for diabetic gastroparesis. The stomach has lost its mechanical ability to break down solid material efficiently. External variables can easily corrupt this data. If a patient is improperly positioned, movement of the tracer from the back of the stomach to the front will artificially increase the radiation counts due to attenuation changes, making the stomach appear fuller than it is. Certain medications will also invalidate the test entirely. Prokinetic drugs like Reglan accelerate gastric emptying, causing a false negative. Opiates delay gastric motility, causing a false positive. Accurately diagnosing gastroparesis means isolating the stomach's true mechanical grinding rate from positioning errors and drug-induced illusions. To evaluate the liver and gallbladder, we use the HIDA scan. This study uses aminodiacetic acid analogs to perfectly mimic the way the body processes natural bilirubin. A normal scan follows a strict sequence: prompt tracer uptake in the liver within 5 minutes, followed by smooth excretion into the bile ducts, the gallbladder, and finally the bowel. If the tracer completely fails to enter the gallbladder after 4 hours of imaging, the cystic duct is obstructed. This is the primary diagnostic criteria for acute cholecystitis. We also look for secondary warning signs. A bright band of radioactive uptake outlining the gallbladder fossa is called the rim sign. It indicates regional hyperemia, increased blood flow, and points to a high risk of gangrenous cholecystitis. A common clinical dilemma occurs when tracer processes through the liver and dumps straight into the small bowel, bypassing the gallbladder entirely. The lack of visualization could mean obstruction, or the tracer might simply be taking the path of least resistance. To solve this, we intervene chemically with a dose of morphine. Morphine forces the sphincter of Oddi to contract. This intentionally builds back pressure in the common bile duct. If the cystic duct is patent, that pressure will force the tracer up into the gallbladder, proving the system works. We apply similar principles in pediatric cases, specifically when trying to differentiate between neonatal hepatitis and biliary atresia, two conditions with drastically different surgical pathways. Because the neonatal liver might simply be too sluggish to excrete tracer, clinicians pre-medicate the infant with phenobarbital for 5 days. This upregulates the cytochrome system, ensuring the liver is completely primed to move the tracer if the physical ducts are open. You do not wait passively for a result in hepatobiliary imaging. You use chemical agents to coerce the organs into proving their functionality. When attempting to locate an active gastrointestinal hemorrhage, clinicians use a patient's own red blood cells tagged with radioactive technetium-99m. Before the technetium can attach to a red blood cell, it must undergo chemical reduction. We use stannous ion, tin, in a preparation process known as tinning. This visual compares the two primary clinical tinning methods. On the left is the in vivo method, where tin is injected directly into the patient, followed by the tracer. It's fast, but it yields a dirty image because only 60 to 80% of the tracer successfully binds to the cells. Contrast that with the in vitro kit method, shown on the right. Blood is withdrawn, mixed with the tin and tracer in a controlled external environment, and re-injected. This delivers a clean 98% binding rate. High binding rates are critical because the visual criteria for confirming a GI bleed are strict. The tracer must accumulate out of nowhere, move physically through the bowel over time, and increase in intensity. If binding fails, you generate free tech, unbound radioactive tracer flowing through the bloodstream. Free tech naturally accumulates in the gastric mucosa of the stomach, perfectly mimicking a high-volume bleed. There is a specific diagnostic failsafe for suspected free tracer. You immediately check the patient's salivary glands and thyroid. Free technetium physiologically targets the salivary glands and thyroid alongside the stomach. If you see activity in the neck and jaw matching the stomach signal, you are looking at unbound tracer, not a true hemorrhage. Localizing a bleed relies on radiochemical purity. Poor binding creates physiological noise, and mistaking that noise for a hemorrhage leads to catastrophic misdiagnoses. The destination of a radiotracer isn't dictated by chemistry alone. In sulfur colloid scans of the liver and spleen, physical size is the deciding factor. This study targets the liver's reticuloendothelial system. Specifically, we want Kupffer cells to recognize the tracer particles as foreign bodies and consume them via phagocytosis. This micrometer scale demonstrates the physical parameters required for that process. For the Kupffer cells to eat the radioactive particles, they must be manufactured to measure exactly between 0.1 and 1.0 micrometers. If the preparation process yields particles larger than 1.0 micrometer, they become too large to pass through the microvasculature and get physically trapped in the pulmonary capillaries of the lungs. Conversely, if the particles are engineered smaller than 0.1 micrometers, they bypass the liver entirely and are absorbed by the reticuloendothelial cells of the bone marrow. We can also see a breakdown in this process known as colloid shift. When a diseased liver, such as in severe cirrhosis, physically fails to eat the perfectly sized particles, the portal hypertension redirects the tracer, forcing the spleen and bone marrow to absorb them instead. The macroscopic visualization of a human organ depends entirely on engineering physical particles down to the fraction of a micrometer. Dynamic nuclear imaging forces the clinician to observe physiological function as it happens. You aren't waiting for a static picture, you track a live process. We calculate exact lag times and map gastric grinding phases, differentiating mechanical failures from drug interferences. We administer opiates to chemically force sphincters closed, intentionally manipulating fluid dynamics within the biliary tree to prove duct patency. We track gastrointestinal hemorrhages using molecular binding procedures, relying on our ability to spot physiological artifacts in the thyroid and salivary glands. We calibrate the exact physical dimensions of a tracer down to the micrometer, knowing that just a fraction of a micrometer difference determines whether a scan maps the liver, the lungs, or the skeleton. Advanced GI scintigraphy relies on total clinical awareness. You must mathematically track, chemically alter, and physically manipulate the living human body to completely separate functional noise from true pathology.